So without further ado, I'd like to introduce our first speaker of the day today, Dr. Allan Shell. Dr. Shell is an academic GP and an adjunct senior lecturer to the School of Psychiatry's Dementia Center for Research Collaboration, Faculty of Medicine, UNSW. He has been the project lead and GP facilitator of a major Alzheimer's Australia NQDCI-funded project to improve the outcomes of a more timely diagnosis and management of dementia in primary care amongst GP patients. This project has managed to upskill nearly 4,500 GPs around Australia. In addition, Allan has also been the consultant liaison GP and educator for the HALT project, with the aim to improve better management of antipsychotic medications by GPs for people living with dementia in residential aged care facilities. His presentation today is titled Dementia, Who Cares? He is going to talk to us and help us understand some of the reasons why the behavior of a person living with dementia may change and determine how best to manage these. Thank you. Allan?
Thank you, Mona, and thank you all for coming along this afternoon. It is after lunch. Welcome, and certainly I acknowledge Aboriginal and Torres Strait Islanders, past, present and future, and acknowledge their, maintaining this land that we live in. So the big topic is dementia, and if you look at our own website, it's a term used to describe a number of symptoms and a large group of illnesses that cause progressive decline, particularly a neurodegenerative decline. And they can certainly impact on loss of memory, or rather retrieval of the memory, their intellect, rationality, empathy, social skills. So it's both a social and a medical condition. And of course there are many types of dementia, and it's not all Alzheimer's. In fact, part of the reason why Dementia Australia came into existence is that people would phone up Alzheimer's Australia and say, look, my mother hasn't got Alzheimer's, can we talk about dementia? Do you do that? So that little plug leads us to Nina, who's out there on the Dementia Australia stand, and you should have a talk to her because she's got a great set of handouts that they can provide either online or physical for you to consider and to give out to patients. Dementia is certainly becoming the second largest or the second most distinct cause of death in Australia, and certainly the UK amongst older females. And compared to when I was writing certificates 40 years ago, you couldn't write that. There must be something else. They must have had a heart attack or a stroke. Yes, they may have, but they're dying of their frailty and dementia. What we're trying to do today is look at how we can manage these behaviours of concern or reactive behaviours. BPSD was a very strong psychiatrist discussion around the behavioural and psychological symptoms of dementia that certainly occur in, it's set up to about 90% of people living with their dementia. We have to look at some of the strategies for families, ourselves as carers and staff as carers. Just around the room, how many people are GPs? Allied health people, nursing care direct, and aged care facility people. OTs? No. Social workers? Pharmacists? Hey, welcome. Okay, so we have most of the team here that is part of assisting in the managing of a difficult disease. And of course, what we need to look at, and yes, we're having a Royal Commission on aged care at the moment, but in fact, Alzheimer's Australia then in 2013 put a big submission up to the Federal Senate talking about the same things we're talking about 6 years later. So that we have to look at a more patient-centred care, not staff-centred care, not doctor-centred care, but around the patient to help manage often what is a reactive behaviour to the situation that that person finds themselves in. So is it increasing? Well, yes, certainly when I started medicine back in the 70s here, that was the sort of the picture of older people above the age of 75, 80. And today, if we look at from the Australian Bureau of Statistics, we've got a very large group of people here. In fact, in my 40 years of medicine or more, people are living at least a decade longer. Like myself, I got a new hip, a new knee, I'm on some medicines. In fact, in the beach support, so I can stand on both sides now, I can do that very well. Can exercise, and we'll talk about exercise. So that medicine today, better medicines, you can have 2 or 3 conditions with 3 or 4 drugs, probably 5 or 6 in my day, and now the drugs today are much better. So people are living longer, better. Unfortunately, age is a risk factor for dementia. And if we look at which of the dementias we're all going to be dealing with, certainly Alzheimer's is the most popular, and certainly the one that seems to start in the sort of 65 to 75 age group. And Professor Gonski, who will be talking to you later, will probably say that even maybe a bit older, but certainly that 65 to 75. And then we have the impact of vascular disease. Therefore, what's good for your heart is going to impact on your brain. So that vascular dementia or mixed dementias will be part of the picture that you'll all see. And of course, there's another group called Lewy body dementia, which is the spectrum of Parkinson's disease going to dementia, and Lewy body presentation with the hallucinations and fluctuating conversations, and then a Parkinsonian type of feature. So we have, that has sort of become, over the last 10 years, a more prominent one of the dementias to talk about. And if we look at the brain, and I think that's an important thing to understand, what's changed, if on the one side there you've got the healthier brain, and you see that what's important there is also the fact that you have these ventricles, which is part of our fluid around the brain system, and it seems to get bigger because as you go from what you call a mild or moderate degenerative disease called mild cognitive impairment into Alzheimer's disease, this gets bigger because the brain has actually shrunk from about 100% of its size to 30 to 50% less brain than we once had, which is quite significant, and there are many reasons for that. And if we look at, certainly Chris Rowe, one of our very good specialists in Victoria, has done a large album of scans to look at, contrast scans, to look at what changes. So you see here, this deposits across here are amyloid tangles, etc., that are part of the Alzheimer's picture. So when you had the original Alzheimer's disease patient and people didn't really know what the problem was, 100 years later, we certainly have, I can't take a biopsy of your brain, but I could do a contrast CT, which is becoming more popular. We can't get them actually as good as these in Sydney, but you can in Victoria. And we can make that diagnosis with the geriatrician, with our input, with a family member to say, oh, plus that, they probably have Alzheimer's disease. Now, what are some of the things that we can attribute to and I'll get onto the big topic shortly, but just to highlight things that have come out to what we can do to not get dementia, and I've got an opportunity to give you a few minutes of that, is that certainly managing your type 2 diabetes well, not being obese, certainly being lighter is better for you generally. Having well-controlled blood pressure is important. Depression is and that will be part of some of the features of reactive behaviors, depression, because depression in an older age person can be a sign of a change and potentially a dementia outcome. Physical inactivity is the big one, where we really have to manage our bodies well, and it will also come into managing that person, the patient-centred care of a person. That exercise really falls off when they typically move into an aged care facility. And if you increase exercise programs, somehow concentration and memory comes back or improves. Smoking, absolute no-no for most of our diseases, and maintaining your education as you're doing all now, and having hobbies and playing bridge and getting outside and being socially active all impact on reducing your risk for getting some form of dementia. Maybe around Alzheimer's, not so sure, but certainly the others. Here's a dear old person in an aged care facility looking very startled because she's thinking, who are you and what am I doing here? This is not my home. So we already have that reaction before things start. So managing people at home is and will continue to be part of the management of a patient living with their dementia, particularly when we have about 200,000 aged care facility licensed beds, and according to Alzheimer's Australia and others, Dementia Australia, there are over 400,000 people estimated to be in the community living with some form of dementia. And I know that when I started talking about this topic 10 years ago, it was considered about 250,000. And by 2050, if things continue, there'll be over 1 million. And for many of us in general practice, it might be 1 or 2 new patients now, and then 3 or 4, and in some older growing practices, 5 or 6 or 10. So it's quite a broad spectrum of what's about to happen. Now it's interesting that it says about 90% has been a number that's been thrown around, are living with their dementia and exhibit some form of behavioural change. According to Senate committee papers, it's considered that about 50% have mild to moderate reactive behaviours, of which 10% are severe. So that means we've got about 40 to 50,000 people with some sort of BPSD or behavioural problem. And of course, if we're at home, that certainly can be distressing for family as carers, and then you as the GP and the staff members as carers. And we know that, of course, there's a want to get them into an institution, but what we're hearing in the recent Royal Commission, and of course from my own experience, there are some very good aged care facilities and some not so good in managing that person with strange, unusual reactive behaviours. And of course they often end up going down to the hospital to have something done, because at the hospital they really know this person, they've never seen them before, they take them off all their medications, and if they're lucky, there's a geriatric assessment team who can help out and remanage that person. But if they're not going back to a good facility, they're back often where they started from. And of course, with dementia, it's a long goodbye. It will end up of that person passing. And therefore, in discussing with families and carers, one has to say that, and there's one of the booths there, talking about dying is something you need to talk about when the diagnosis is made, not when it's a bit later on and things are obvious. So what are some of those reactive behaviours? The most common ones are this broad list on both sides of the fence there. And if you go down through them, you'll see that a lot of those particular presentations are treated with medicines. Doctor, give them something. Staff, I can't control that. People at home, you've got to give them something, doctor. I can't stand this. You know, my mother keeps repeating the questions all over again. She's following me around the room. Sometimes she's crying. But unfortunately, if we look at that list, not all of them should be given medicine. They really shouldn't. And from the HOT study that Mona talked about that I conducted with others just over 4 years ago, we had 25 nursing homes across Sydney, 50 GPs I interviewed and I guess detailed about what is better management, and certainly too many of the things on your left were what they're being treated for, and not just for their true physical or verbal aggression or serious agitation, or in some cases were people who have that Lewy body type of psychosis or some of the other dementias, delusions and hallucinations and occasionally delirium. So we really have to be careful of how we're going to manage that. And depression that's there as well can be very difficult often to manage in a person with their dementia. It's not quite the same as a reactive depression in a younger person. And I think thirdly, and not to be flippant, there are more older ladies on an antipsychotic drug than there are people with schizophrenia being treated for the same thing. So in some ways, we are and have over-medicated some of our older patients with difficult situations. And even amongst Indigenous health, I did an Indigenous health workshop up in Northern Territory. I mean, I'll let you look at it. It's very informative because men are more at risk, they act differently, they get trouble looking after themselves, they growl. In fact, what happens there is, funny thing is, they often growl or shout at the little kids that they usually were very happy to play with. And who's been watching this wonderful aged care home for 4-year-olds? Of course, everybody. So the wake up there is re-engaging people, and they certainly don't appear to have dementia, but sort of re-engaging people changes their whole outlook often, and their activities, and their distress about getting older suddenly not disappears but dissipates. So again, treating people with respect. So just because you've got Dementia Australia used to say, doesn't mean you stop living. We really have to talk about other sort of, there's a new article I saw the other day that, it's really terrific. We've got a new program here. It's called Integrating the Person to Get Used to the Lifestyle They Left. In other words, they're in a new home, so let them help do some of the cooking. Let them help do some of the cleaning. Don't let them just sit in a corner in a tub chair watching white noise on a television. So again, we have to know who was that person before they had their dementia, what were they like, and what were some of their activities. And the big issue around dementia in the Australian Aboriginal population is that if you make that diagnosis, they may not be able to tell their story. They may not know where their country is. They may not know their kin. So you have a cultural thing. Looking around the room, you have many cultures, that's Australia, and you'll be coming up against cultural differences. You may think that my Anglo-Australian talk is appropriate for you, but it may not be for the person of a different cultural background. So we know that these things have been happening, a whole lot of studies being done, including Professor Brian Draper, and that we know that they're often physically restrained, but that's changing. We know that being on antipsychotic, and I tell you that the 25 nursing homes of 200 patients, after 1 year, 50% of them were no longer on a medication. So for the pharmacists here, we assessed the medications. We had 2 staff members, a morning and an evening staff member, observe, because there's the issue around sundowning, that time of day change, how the person reacted, who they reacted with, and in some cases they were on inappropriate medicine for too long. So they were taken off that medication over time, over a few weeks, halving the dosage, observing any changes. In fact, for a lot of patients, they seem to get better. On top of that, we involved the OT to come along and help them do some activities that were more appropriate for what they used to do or used to know, etc. And I think that what we also have to do is talk about it with families, because many families were scared that, if you take them off the medicine, they're going to change, they're going to get ratty and aggressive again. Well, it's quite the contrary. In some cases, they were much nicer. And once they got re-engaged with activities, they were more manageable. So the staff said, they're easy to look after, and I've got some more difficult patients. So I think that this issue around nursing stress often jaded the doctor's impression of what to do, and in some ways accessed the drug cabinet and handed out some of the medication we know can dampen down some of those particular symptoms, but equally make the person feel like blotting paper and not be able to do much more sitting in their bed or their chair. A whole lot of things to think about, but what we do come down to is in training staff, which we did. They had a 3-day workshop on looking at who the person was, what are some of the disengagement programs you could instigate if somebody got aggressive or agitated, etc. So I think you have to look at nurse education. Okay, we all would like to be medicos, we all would like to be in the health field, we all want to learn about the medicines, but patient-centred care is something that's important. Look at who that person was and what sort of activities we can do to re-engage them. Now we know that some of these changes are due to biological, some of them psychological. One in particular is the unmet needs, and there are issues where I certainly had it when I came to visit that an older lady would come up and give me a hug, and they'd have to prise her off me because I was a man. She knew she wanted to be hugged or cuddled, so we know that aromatherapy, sitting down with that person when they're a bit agitated, stroking their hand, talking to them quietly and directly, often reset them. You gave them an emotional meta-need. You helped them feel that they were a person again, that they were being loved. People have even invented sort of hugging coats where they can walk around. There's, of course, and I'll come to that a bit later, the doll therapy or the stuffed animal, where that person has their unmet need of emotional contact sort of related to a doll or to a stuffed animal. Again, we've had dogs and cats in aged care facilities, and a bird and an aquarium. Dogs, unfortunately for some people, in their memory is when they were attacked, or from another culture, that dog brought rabies to the community. So we have to worry about animals, but stuffed animals seem to work until another more alert person says, "What are you playing with a dead cat for?" People are funny, that's true. And of course there's stress, okay? And the stress may simply be this sort of ABC reactive. They sit down with Mona here at dinner and they decide they don't like her because she's wearing a red coat today, and that red coat reminds them of something bad, etc. And they get aggressive and their behaviour changes, and the consequence is they get dragged screaming out of the little dining room that they're sitting in. And so some people may be better off sitting alone at the table. Some people may be better sitting with a male. Well, unfortunately, we males seem to be outnumbered by many women in an aged care facility. You seem to live longer. But again, it could be that the other male there they didn't like, and there's no reason other than there was a reaction, or that the person coming to talk to them was wearing a white shirt, black trousers, and happen to be wearing his black gumboots to go to the shower, that's a policeman coming to take me away. So again, where did it happen? Observed by others. So we get these unusual antecedents, the behaviour and the consequence. And of course, stress. Okay, well, there's a lot of stress just sitting here talking to you. On the other hand, people might say that, oh, it's too quiet here, that's stressful. Or it's very noisy, it's too stressful. So we have to look at stimulation, light, blue light's favoured, or too much light. Or there's just simply sitting somebody in a garden is peaceful, de-stressing. So again, all these little things we know about aren't being really done that well in aged care facilities, but we certainly can instigate many of these at home. And if we look at the last one here, which Dementia Training Australia is putting together, the book, the mirror and the landscape, that is, what's the book and that person? Who were they? Who do they see when they look in the mirror? Because it's quite often that they're taken to the shower and they look in the mirror and said, who's that? What's that person doing in my bathroom? They do not recognise themselves sometimes. And the environment that they're in. Too many places still are all white, all clean, all hospital looking, not this is my room because it's got my, oh, that's my dressing table and they're my things. Oh, it's a photo. Or there's a family. I mean, Montefiore, upper class, I guess in one way, but has memory box system where you've got a memory box. That person's room, oh, that's my room, there's my memory box. So there are things in the landscape that we have to do to reduce the behaviour and the consequence. Equally, Jim goes into Fred's room because that's my room, get out of my bed. Because the place is all white, he can't find his way back to his room. He has no direction in his landscape. So you get a lot of aggravation and assaults because they're in the wrong room. The other one, of course, happens where consequences of staff getting very angry because this person is not behaving. So we've gone the other extreme of staff members often overreacting to this ABC thing here, the behaviour of the patient. The consequence is that, as we know, somebody got filmed sadly assaulting a patient. So this is a whole conundrum of humanity. And again, if you're sitting in this situation of assessing what's going on, we realise that you need to have at least two people at different times of the day to say, well, is the description of what happened accurate? What happened? Does it require some intervention? And of course, non-dementia causes, which we'll talk about, which are and have to do with often infection or fractures, possible change in medicines that you caused, the iatrogenic cause, and some of their impairment. They can't see, they can't hear, and we know that false teeth get lost, spectacles get lost, hearing aids certainly get lost, and therefore that impacts on an impairment and then has an outcome. If we look at one of the behaviours, and I've done a lot of talks, and typically I have a specialist colleague, psychogeriatrician, old age psychiatrist or geriatrician. One was simply of a farmer, she found out a farmer, a gentleman who was incontinent of faeces sometimes and urine, used to love wearing his overalls because he was a former farmer, but staff didn't really take notice of that. And often when he was incontinent and dirty, they couldn't let him sit there at the dinner table or breakfast table, then they want to take him to have a shower. Well, he was screaming and they needed 3 or 4 people to drag him out of there. So my young colleague came along as the health specialist and said, now what did this gentleman do? Oh, he was a farmer. What sort of farmer was he? Oh, he was a dairy farmer. Oh, okay, dairy farmer. Bill, look at you, mate. Look, the cows have shitted all over you. Been out there milking. If we don't drag you back in that shower, your wife will be very upset with you. You can't go like that to breakfast. Oh, okay. Off you go. Or the gentleman who read a newspaper each morning at home. Slowly his frailty overtook him a bit and his dementia couldn't be managed at home. Sat down there, he'd be reading his paper in the room, and they'd come at 7 o'clock, time to have a shower. Come on, let's go, Bob. No, I'm reading the paper. No, you can't do that. So again, that person loved to read the paper, have a cup of tea, then have a shower, which, that's at 7:30, and I've got other things to do. You can't do that. So you have to be careful of, and it's not going to be all your patients. It won't be all of the people look after. It'll be some. And if you manage those in a patient-centred care way, things will improve for you as the staff member. And I think that staff members who haven't done a university RN degree or have come from another culture enjoy being trained to understand what's a better way to manage somebody with good care, but with a bit of scientific research knowledge that we should be doing here today. We'll have questions, I'm sure, afterwards. But there's a very obvious thing here that we need to reassess what we're doing for some of our patients. Not all of them, because that may not be possible. For many, it's going to help you and me manage that person a lot better. And at all times, one has to be talking to, and in the majority of cases, there is a responsible person, a family member, a carer, sister, brother, aunt, uncle, whatever, who'd like to know. The big mistake I had once was my mother visiting an aunt who she loved, who got older, ended up in an aged care facility. And sadly, when my mother turned up, that made the aunt suddenly confused. She didn't know why her niece was coming to visit her. Why are you coming to my home? You shouldn't be here. So there was a lot of verbal and physical aggression, I guess not serious aggression. And so my mother went away very distraught, and for the next 2 days the lady was upset. So the staff said, an observer said, I think your aunt has a problem with your mother. But why? They love each other. No, I don't think so. I think your aunt has got used to this landscape. This person is intruding, and she doesn't know why, and she can't manage that. I had the same with a dear patient who the only thing he could do was shout, no, wah, 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 because he had a bad stroke, he had diabetes, and he was dying. And every time his wife came, for the next day or two or a few hours, there was a problem. To the point where the staff, look, we got a problem with the wife, can you do something about it, because it's distressing the husband. So the other thing that's important is to know what was the relationship between people before that person went into the world of dementia. So I had a talk with the family, the sons in particular. I think we know what the problem is. Why is that? He hates the wife, our mother. They didn't have a good relationship for the last few years before he had his stroke. So this sort of relationship, the pre-morbid personality, is a need to know. How were they? Or the member of the family who comes from overseas after being away for 2 years is the lost son who that person loves, but the daughter who comes every week to see her is a terror. Look, you put me into this place, and look at your brother's so nice, he comes to visit from London. So you've got to look at personalities as a cause for that reaction. Something often not obvious unless you know who that person is, what's their book, what's their story. So we have this framework that they talk about, the socio, the interpersonal, the biological, psychological. So if you look at some of the intrinsic or the biological, these are some of the causes for those disturbances. On the frontal lobe is probably one of the more distressing for all of us, in that frontal lobe, frontal temporal type dementias often have more of an emotional, verbal, often bad joke scenario before the physicality, the frailty comes along, and often the most distressing for carers and for staff. We know that this sort of Parkinson, Lewy body spectrum, all these things are the psychoses in different parts of the brain, and we know that sometimes dopamine for a patient who's been for treating for his Parkinson, in fact has Lewy body dementia, and may in fact get worse because he doesn't really need more dopamine, L-DOPA, he needs something else, and we'll talk about that something else shortly. And of course, people ask, is there a genetic predisposition to some of these things? Yes, for some of the serious things like Huntington's chorea, which are in the younger onset vein, and those younger onset, they have often a different type of behavioural and dementia profile. But others, for the rest of us, in my aunt or uncle, actually quite a few, have had dementia in their 80s. So more probably of a vascular type of dementia. Genetically, because your aunt or uncle over the age of 75 and they were in the last generation made it to that without having some form of dementia, probably vascular, age, yes, age related, but age is not the absolute cause of it. So we know that ApoE, ApoE4, which is part of a cardiac assessment profile for increased incidence of cardiac disease, may be associated also with dementia. And as I said before, the family, we also had a member of the family who married a young lady whose mother had died and her sister had died around the age of 50 from a Alzheimer's type disease, and sadly Karen also passed away at 52. So we know that in some families there are neurodegenerative causes, but they're in the realm of younger onset, which tend to be around 25 to 30,000 of that 400,000 persons living with their dementia. So the big picture is more of Lewy body, Alzheimer's, vascular type mixed dementias. I don't want to bore you too much, but we got onto a bit of some of the reasons why we have these disorders. And of course, the one is their executive function. If your frontal lobe's affected, then your decision making, your empathy may change. Equally, you may get more disinhibited, and we've heard many stories about people telling bad jokes or doing silly things, such as it was noticed that the nonna, a nice older lady, was she was the queen at the little grandson's birthday party, but she went around pinching all the bottoms of all the little boys who were not her child, and getting a bit too emotive with her hugging. And then they looked at, well, okay, let's go and do some pasta, Mum. Okay, well, she forgot where the sauces go. So when you see a change in that person's sort of reactions, their physicality, their daily living activities, and it may take 1 to 2 years for you to pick up that problem within a family or within your patient. And some of these behaviours are in fact part of the change in the brain. The other one that's quite fascinating, I think, is, well, they call it agnosia, the inability to recognise familiar things. There's a thing such as anagnosia, meaning that anasognosia, person not knowing that there's something wrong with themselves, and knowing that in this society across Australia, there may be about 20% of the population of older people living alone, or ending up like in that special home for older people with 4-year-olds, that there are a number of older people who are put together in a retirement village, but in essence they're still living a little bit alone. Now, these things are some of the causes. Again, we talk about how can we manage some of these reactive behaviours. These are some of the physicality, the extrinsic, a little bit of a hernia. I've had that problem with a female patient who had a femoral hernia. Now, for many of you, we think that men usually have hernias in the groin there, but women do and can have femoral hernias. That's just down in the groin area, in the line that you feel, the crease between the abdomen and your leg. And that lady had uncontrolled pain, except when she was lying down, because, of course, the hernia would disappear. But when they got up to walk around, she was in pain. But we really couldn't work out until you said, we'll get a second opinion. Maybe there's a surgical problem. Yes. Medications. You, as the GP, have changed the medications slightly. And we talk about the cholinergic load, where you've added something into the medicines that you didn't have before, and that's enough to tip the balance. Pain syndromes. They did a very big study, Henry Bedard, I think, was part of that, where people who had this sort of agitation, possible arthritic pain, were given 2 Panadols 3 times a day, paracetamol, sorry. So the equivalent of 500 milligrams at least 3 times a day. In 30% of those patients, after about a week, there was less agitation and irritation amongst those patients. So some underlying pain, it may be arthritic, and arthritic is tolerated by different people in a different way, is a problem for them to be agitated or aggressive, etc. Constipation. In the old days, everybody went to hospital, they were given an Aperiod and prunes and everything. Oh no, you really can't really do that because that'd make a mess of the bed, so you end up with constipation for 5 days or something. So again, all those things are obvious, bleeding obvious sometimes. And of course, basic needs and hunger and thirst. So you get one poor patient, again, a story submitted by one of my colleagues, gentleman being accused of sexual disinhibition. He keeps touching all the staff's bottoms and breasts. Okay, so my very nice colleague from country Victoria comes along to the nursing home, and she comes to meet Bill, and he's sitting in a wheelchair. Okay, why is he in a wheelchair? Oh, he's quite frail, we have to sort of wheel him around. So when he's in pain or thirsty, he grabs something at that level. So what's at that level? There's either a bottom or a breast. So if Bill, is there something wrong? You've got to get down to Bill and see what the problem is. And he might poke you in the eye, but he won't touch your breast anymore, will he? Because it's... So look at basic needs. Thirst is a very often a sad, simple cause, and they may be on a fluid restriction diet and all those wonderful things that we doctors think are good for their outcome because this person's going to live forever. No, they're not. They're living, unfortunately, waiting for God. It's a very difficult and complex world that we live in when we're looking after patients who can't tell you what they really feel is the problem. We often have to second guess or third guess or fourth guess. So again, very difficult, and I appreciate that, but we have to look at all these things in assessing a patient. And the environment, as I talked about before, the white walls, the white this, the white that, and if I went into the beautiful bathroom here, which I did, down the hallway to the right, black walls with a white urinal. At least I can see the urinal, but in some places it's all white, all white, all white. The toilet seat is missing. Oh, okay. So that environment should be related to that person, and I'll get to a very good point shortly. Too much stimulation, again, the noise and etc. They want a quiet room, or they want to be busy doing activities. They want a bit of space to wander around, and that can be very difficult in confined motel type aged care facilities where there's no room for anything. So I think having a wandering area, and there are many planners who've come up with wonderful ideas about having a bus stop in the garden, or a little broken down car for the mechanics to fix, or somebody to go and sit and wait for the bus because they're getting very agitated. Oh, Morris, let's go. You've got an appointment today. Oh. So you walk down to the bus stop, sit there, there's a little road and a bus stop there. This was done in Tasmania some years ago. It works. And then you're sitting, oh, look, you know what? Oh, the timetable, look, I think we've missed the bus. Let's go back inside and have a cup of tea. And things are quietened down, whatever the reason. Now, privacy is important. Intimacy, yes. You can't have sex, I'm sorry, it's out of the question. What? So there's masturbation issues. There are simply a gentleman jumping into somebody's bed and another having to be female. There are problems there. And there are those that actually wouldn't mind having a sex worker come once a year because that's going to help improve their unmet need. Equally, around about bathrooms, there was a very nice story from my Northern Territory visit about a lady who eventually was given up by a community and stay in a nice aged care facility, but she would often go and wee in the garden or wee there or do that at the most inappropriate times, till my very good colleague said, you know what, why don't we make the bathroom a bit of a bush setting? We'll put some plantings and a bush and we'll hide the toilet seat behind the tree. How do you think that'll work? Marvellous. Doris, would you like to go bush? Oh yeah, I'll go bush. And so therefore you've changed that landscape for that person. Okay, so we haven't done much other than who that person was, what is she wants maybe a bit of privacy, but she didn't know where to go, so she did it anywhere. You give her privacy, she's very happy, etc. So I think I've painted that picture quite nicely. And of course, it has to be secure. We have had a number of institutions that have a library and the door to get out has got a bookcase on it. So the patient won't go to get out of the library because there's a bookcase, or there's, 5 minutes to go, I'll get there. So again, it's the environment. So back to that landscape. We have to make it home-like. And as we say in this very nice program here, home-based activities, cooking, cleaning, gardening, laundry, anything that may facilitate that person to participate and manage some of their agitation. And certainly in managing day and night, which often is a reason why they get over-medicated at night in order to sleep. But if you don't give them exercise, and there's plenty of exercise, sitting in the chair, getting up from the chair, getting the physical therapists to come in, have little pedal bikes, walking things around, doing the gardening, anything that creates a rhythm of life during the day will help people sleep very nicely at night. And you see there simple things such as their own place. I haven't got the colour version, but obviously there's plantings, there's a picture, there's a memory box there, they know it's their room, and you can even sit outside and just watch the world go by. We know that aromatherapy works very well because people enjoy that past experience of a bit of a hand massage, not too intrusive, where with lavender oil, lemon balm. Again, that was from the very good Cochrane review. They've done a lot of meta-analyses of lots of things, but they found this one was quite valid. And of course, family of carers, getting the person who cares for that person involved, and particularly when they're at home. You know, this whole thing about stress, they're getting angry about the repetitive questions. Well, sadly, that's going to be part of the system. They're getting aggressive towards a member of the family. Get somebody to observe, when does that happen, what's it about, should that person come and visit, and often it's towards the daughter who's caring and not to the son who's coming to visit. So that's a very difficult one, but often it's the cause of the aggression in their dementia mind, not because they hate their daughter. They love their daughter, but things have changed. Often it's frontal lobe. And if we look at the cost to the service, patient-centred care, usual care is in that blue line, and as you see with patient-centred care or dementia care mapping that person's activities through the day to find out what does or doesn't work, very cost effective because you needed less care in the blue line, more care in the blue line, sorry, and less care on the other line. So again, think about how you can change the way you care for a person. And patient-centred care, Lynn Chenoweth, very good professor at the University of New South Wales, done lots of work, and you'll find lots of papers on her, and she certainly helped us to educate our aged care facility staff when we did the HALT project. And of course, we talked about that, managing unmet need. I want you to go and look at, you've got a YouTube version called Henry's Music. You can write down those numbers and they will be printed out, of course you'll get all my slides. Now, just Henry's Music is a dear gentleman in an aged care facility who does not recognise his daughter when she comes to visit every day, but when they put an MP3 player and play his favourite music, you'll see he wakes up, he has a 5-minute conversation with you as if nothing had happened. And it's often when you see and talk, oh, my mother hasn't got dementia, you know, she's, I can have a normal conversation with her. But there are these sort of fluctuating conversations. So your dementia interferes with some pathways, but if you see Henry's Music, you'll see that he's enlightened, he's re-engaged, he's awake to his music. So again, music has become another thing. We did a study then, I'll show you, with volunteers, music, singing, humour, creating puzzles, creating magic, decrease depression, improve quality of life, re-engage people in the community. The pets, robotic toys, dolls. Again, people and families have to know we're not belittling your person, we're not demeaning them. We want them to be re-engaged, as with the cat there. The furry, this is a Japanese purring seal, cost about $300, but when you stroke it, it moves. So again, that unmet need of making contact with a fluffy toy animal makes a difference to reducing the agitation and stress for that person. So what we need is an understanding. We need to give the person time at the beginning. Once you've worked out what the issues are, you can manage their time and your time a lot better. And the same goes when that person is at home. Some of the barriers I picked up with the GPs and with staff, they didn't have the time. There wasn't enough money to train staff, the end staff. And there was a big attitude block to, well, it's not going to work for everybody. No, it's not going to work for everybody, that's true. But in fact, it may help you manage those that require a bit more time. We do have some pharmaceutical interventions. Acetylcholine esterase inhibitors, I'm sure my GPs have heard about those. They were invented to cure Alzheimer's. It didn't quite work, and in about 23% of cases, they will improve outcomes in a person with agitation, with some sort of motor problems. However, it only works in about 23 to 25% of those patients. But what it does really work for is the Lewy body dementias. While it's not classified as being, at the moment, a treatment option for Lewy body dementia, it does help manage that Lewy body dementia a lot better than some of the Alzheimer's patients. Improves their behaviour and their agitation and the hallucinations which they often have. And we have to look at this big fact that polypharmacy, in other words, people on a number of drugs over a number of years, but their renal function has changed, liver functions changed, their ability to reduce drugs has changed. So talking to the pharmacists here, many GPs around Australia still are very fearful of having a pharmacy review of their patient. And for a lot of pharmacists, there may be a bit of a misunderstanding, why is this patient on all these old drugs, they're a problem. But it's worth looking at the impact it has on their chronic disease management, because as a person gets older, there are some medicines they may not need, and there may be some medicines that are actually causing part of the problem. So we need to reduce that so-called cholinergic load. And we know that apathy, hallucinations, in Lewy body dementia in particular, as I said, have had a good clinical outcome, even though those drugs in particular were for straight out Alzheimer's disease. The other one we have for all these, I've got another 2 minutes, sort of behavioural and psychological symptoms are, should we use antipsychotics, which is the new breed of medicines we're trying to use? Screaming no, wandering no, entreating, all the things I talked about before, no aggression. Well, what was the aggressive situation? But if it's true, verbal and physical, yes, there may be a cause. And certainly delusion and hallucinations that are not causing a safety issue. While they may be seeing little animals or something coming out of the woodwork, it's not disturbing other people and it doesn't cause that person to become unsafe. Till they get very confused and very agitated, then yes, there may be medicine. So we do have, and Peter and polypharmacy talk, I guess later on we'll talk about that. Citalopram has been effective in improving hallucination delusion outcomes, but there's a problem with a cardiac patient. Sertraline has been helpful. The other one is Seroquel, quetiapine, which has been effective, all in low doses. And they have, in fact, had some benefit to calming down the situation, and they must be reviewed over a 3-month period to reduce them back to 0 if one can. Or if you've halved the dose and some of the symptomatology come back, go back to the last half dose and then keep them on that for a while and see how you're going. The one thing about acetylcholinesterase inhibitors, such as ninezopil and rivastigmine and galantamine, they have been shown that if you move a person into an aged care facility, you probably shouldn't take them off that medicine at all until there's a point where they can't swallow or take tablets. So that over time, you could reduce it slightly, but if they're well on those medications, don't stop them for quite a while, because that person may in fact get a bit worse and the family will get upset with you. So I think that I've talked about most of these things. Person-centred care, right liver stimulation, attention to environment, and treat the physical disorders, and that's on our dementiaresearch.org, New South Wales. There's a very good BPSD guide that one of our PhD fellows did, or lady did, and I think that you should look at that. Again, dementiaresearch.org.au, the BPSD guide. It's available, it's free. And finally, an ad for myself is there's the Think, any people register with Think GP? Think GP is a free access education to all of you. You can register for free with your email, etc. And we have a number of modules in the aged care segment on some of the things I talked about today and more. And you can get brownie points if you want for nursing, you can get points for GP, and you get just benefit to yourself because you've done the ALM. It asks you questions. If you don't get them right, there's a drop-down box to help you know what the right answers are. Thank you very much for listening.
We're going to open the floor to questions and answers. Does anybody have any questions?
Yes.
Some time ago, we heard about some research being done with the biologicals and with improvement in Alzheimer's dementia. Is anything come of that particular?
You mean sort of those yogurt drinks?
Yeah.
Well, I think the best things they have shown is the Mediterranean diet for we Westerners has been a significant improvement in not giving you vitamin tablets and fish oils because you're having fish, you're having good veggies and fruits on a regular basis, so good nutrition will improve everybody's outcome. Secondly, reversing the disease, I think, is the most difficult, except where you have a vascular component where you manage the person's blood pressure and diabetes well and have them exercising as part of their management, then you will see an improvement. I don't think there's anything, and people have tried ginkgo biloba, they've tried turmerics and all the other spices. For people of the non-Western fraternity here, which I can see many of, the Asian style, East Asian diet has been very good for that population to get to the 21st century. But if they start having, as has happened to the Aboriginal population, moving to a bad Western processed food, white breads, jams and things that are not nutritious, and they're high in carbs and therefore fatty, they're bad for your health, bad for your arterial tree. So we should really review our own dietary requirements, our own background. You know, certainly alcohol for some population, a glass is okay, but for others it's terrible, it's damaging because it's not in their culture. It's not in their genetics over the last 5 centuries, whatever it is. Good question, thank you. But and certainly listening to Professor Bradati and others, I mean, even Peter, you can ask Professor Gonskiat later, issues around frailty as well. It's got to do with exercise, it's got to do with good nutrition, bone health, vitamin D, calcium, all the things you should be getting from a good nutritious diet. And that's often been the negative thing about some homes where, oh, we're feeding them. Yeah, but look what you're feeding them. Well, they can't eat. Well, because you haven't tended their teeth. So I did a course with the Australian Dental Association. Dental care of older people is terrible. And they forget, oh, there's the toothbrush. Yes, there's a toothbrush there. What do you do with it? No, I don't know. They've forgotten, in fact, function. Their activity they're living to brush their teeth has disappeared. If they've got, and many did, have dentures, the gums aren't well looked after. It's a vicious circle, really. So unless you're having very nutritious spaceman food, you know, packeted stuff, oh, that's expensive, can't give them that, we'll just give them mashed up something. Again, you don't need those expensive nutrients that you can buy in bottles, you should be having good, wholesome, down the road supermarket, fresh fruit food. Anybody else? It's a big topic. I'm sorry that I usually do this in 6 hours. So please look at the Think GP program, because you will find a couple of topics that you will be interested in, and there's a lot of reading there, so there's a lot of good reading coming out. And really, only over the last 30 years have we improved. Certainly my education on dementia was from the late Professor Lance, who talked about senile and pre-senile dementia. That was it for 1 hour. And I talked to over 400 GP registrars each year, one of the courses I do. And really, if you haven't been to an aged care facility or been to somebody's home, you won't see what the environment is like, and you won't see why they're reacting the way they do. So good luck, and thank you for listening.